45-year-old gentleman presented with a failed graft and NO3 grade cataract. His 20-year-old graft showed thickened Descemet's endothelial complex with variable stromal scarring suggestive of a failed graft. His biometry revealed a 5 mm difference between both the eyes. This also confirmed on B scan showing a posterior staphyloma. The previous graft size was 7.5 mm. We began by debriding the epithelium to enhance clarity. A temporal 2.8 mm scleral tunnel purposefully placed short of the graft host junction, ensuring that our cataract wound stayed away from future keratoplasty sutures. Two limbal side ports were created, again avoiding the graft host junction. A 5 mm central capsular excess was initiated at the area where we can visualize the bent cystotome clearly, and in 1/5 motion we complete it in the areas where you cannot see using a forceps. Following which we do a Phacoemulsification using the stop and chop technique. Here what we try to do is always make sure that the probe is going in areas where it's clearly visible. First we create two perfect halves, and then we elevate each half of the nucleus into the anterior chamber, and we gently try to emulsify it in the anterior chamber. The advantage being there is no endothelial damage happening in these cases because we are anyhow doing a future keratoplasty, and then we are avoiding the risk of PCR from happening. Once that is done, we move on to a cortical cleanup. When we are doing it under coaxial illumination, you can see that the cortex is very clearly visible in the periphery, which is what you need to remove the cortex easily. We first try to remove areas which are easily visible, then we try to venture out to areas which are not quite easily visible. Once cortical wash is complete, we use a single piece non-aspheric IOL. We directly inject it into the bag and tuck the second haptic into the bag as well. The pupil is constricted using a pilocarpin. The main wound is secured with a single 10-0 monofilament nylon suture, and conjunctival closure is achieved with cautery. We then proceed to keratoplasty. A 8 mm trifine was centered meticulously over the previous graft, and a partial thickness groove was created by just rotating it on the cornea. Entry is using an MVR blade followed by 360 degrees excision using right and left-handed corneal scissors, making sure we are not leaving behind a lot of posterior corneal ledge. We also make sure before we complete this excision, the donor graft is punched and ready. Then we use interrupted sutures with 10-0 monofilament nylon. First we are securing the primary sutures, first at the 12 o'clock position. Then we go across and take the second suture at 6 o'clock position. In the same fashion, we continue it, and once we are complete with 8 sutures, we start replacing viscoelastics with saline. Once all the sutures are secured in position, we completely remove the viscoelastics and replace it with saline. Postoperatively, topo-guided selective suture removal at 3 months yielded an unaided vision of 636, with limited further improvement attributable to long-standing amblyopia. Scientific rationale behind our procedure: because this is a repeat graft in a high myope, combining cataract surgery with keratoplasty would significantly increase the risk of retinal detachment. A staged approach reduces vitreoretinal traction by minimizing the duration of open sky surgery. By performing Phaco first, we create a safer intraoperative environment and lower the overall posterior segment risk before proceeding to the repeat graft. Thank you.